And I think on Friday, which I feel like seems ages ago for some reason, I had sent the recording of the last lecture, and I had given you it's a handout about pulmonary circulation. So when we did the blood flow through the heart, and in that handout, I wrote exactly how I want you to put it on the test. It was at the bottom of the handout. When you went from the pulmonary artery to the lungs, all I said was pulmonary artery, lungs, CO2 for O2. The handout I sent on Friday talks about what's happening in pulmonary physiology, and it talks about the blood flow through the lungs. So that's going to be different for this test. It's basically everything you did on the last test, except we're adding, when we get to the lungs, you're going to break it down. And that's what it's going to be. So hopefully you got that handout. It was attached in the email. But the last thing I ended with was I had talked about, well, let me get back to the picture. When I talk about this thorax, okay, it is like a cavity, okay? Inside that cavity, so the borders of the cavity are the ribs, which are, and then so you've got the ribs, and then you have the muscles in between the ribs are the intercostals. Okay, the front of the chest narrows. When you get to the caudal thorax, the wall or the dividing line is the diaphragm. So the diaphragm, the ribs, and the intercostals all make up the borders. There is a space, and that space, the thoracic space contains obviously the heart, the blood vessels, and the lungs. But how do the lungs function? The big thing that you need to know, and this is important to understand, is there is a vacuum in the thorax. The thorax has something called negative interthoracic pressure. Okay, so imagine that space is like a vacuum. Now, the lungs are passive. I want, maybe in your head, say that 5 times. Burn it in your brain, write it on a piece of paper. The lungs are passive. They are not muscular. They do not move themselves. They're just like passive sponges connected to the airways sitting in the thorax. So what happens is when the thorax expands, now remember I told you the muscle, excuse me. Okay, just choking on granola, it's okay. When you expand the chest, what happens is the external intercostals contract, and that pulls the ribs open. The diaphragm, which was bent inward, it flattens, and that pulls the chest. Now, remember what I told you, that the base of the lungs touch the diaphragm. So if the diaphragm expands and the ribs expand, the lungs move. They're kind of like, oh, now we have all this room. When the lungs expand, it's because the vacuum of the thorax expands and it draws air into the lungs. So the movement of air into the lungs, or the lungs itself, is passive. They follow the space allowed. The other thing that happens is, remember, the vena cava is coming back through the abdomen, coming through the thorax to the heart. Every time, because remember, veins are not very muscular. It says here, right here. What happens is, as this chest expands, it acts like a vacuum, and it's going to help suck blood from the vena cava back to the heart. So it kind of acts like a pump. Now, if we break it down further, inspiration, which is inhalation, is air coming into the lungs. Right here, lungs follow enlargement passively. That's how the lungs expand. The chest has to expand. The inspiratory muscles that you need to know, the diaphragm and the external intercostals. There's 2 layers of intercostals, external and internal. Now, when it's time to exhale, that is the process of pushing air out of the lungs. What happens is the intercostals, internal intercostals, I should say, and the abdominal muscles. So the abdomen pushes, which forces the diaphragm to go back to its normal curved shape. And then the internal intercostals pull the thorax in. Well, what happens is the size of the thorax is decreased and air is pushed out of the lungs. I'm going to see if I can do something. All right, bear with me. Can everybody see a big blank board? Nope, that's not what I want. Okay. Now, if I was in a classroom with a board, this is when I joke and I tell people that I was not hired for my art skills. I was hired for my knowledge. So I want to give you an idea what's going on. Okay, my poor cat. Wow, look at that long whisker. You get the idea. You guys are like, oh my gosh. That is the abdomen, okay? VC is vena cava. That looks like a flower. See where I have O2? These are the lungs, okay? When I ask you, which usually means I'm going to ask you, where is positive pressure? Positive pressure is the oxygen inside the lungs, okay? The lungs are supposed to have oxygen. This space around the lungs is negative pressure, okay? Now, and then there's not supposed to be pressure in the abdomen. So right now, this is an intact diaphragm. This is this line, and then this is the thoracic space. Now, when this animal, this cat, this, say that's the trachea, okay? There's the trachea, they inhale, the lungs expand and contract, and if you know, the heart is in between the lungs, and the vena cava is coming back from here, coming back. Now, let's say, for example, this cat gets hit by a car, and the cat fractures a rib. So it's hit, one of the ribs breaks, and one of the ribs punctures the lung, okay? So now, all of a sudden, air is leaking out into this space. Then we create something that's called a positive chest. Do you see what I'm saying? Do you see what I'm doing here? What's happening now is air is escaping into this vacuum. Do you think the lungs, if the thorax starts to expand with air, are the lungs going to be able to inflate? Because what's going to happen is air is going to take up that space. So what happens is an animal will try to inhale and exhale, but the problem is the air is around the lungs and it's going to compress them. This is called a pneumothorax. A pneumothorax is air in the chest. Now you're like, well, there's supposed to be air in the chest. Not in the chest. It's supposed to be in the lungs. The area around the lungs is supposed to be a vacuum with no air. So what we do in a trauma or this and that is we will take a needle, okay, we'll put a needle in here. It's my syringe. This is kind of fun. Okay, there's my syringe. And what you can do is you'll start to suck out the air that is around the lungs. And then what starts to happen is the lungs can expand again. Then what we do is we create we reestablish negative pressure. Now, the question I usually get is, how long does this take to heal? Because now we may have a patient in our ICU for several days, maybe a week, and then what you're looking for is, we may have to tap a dog. This is called a chest tap. And so someone will say, let's go tap that dog, meaning we have to put a needle in there and suck off the air. We may have to do that twice a day, 3 times a day, sometimes only once a day. But the goal is, say we got 300 mils of air on Monday, 200 mils on Tuesday, 50 mils on Wednesday. We see that the air, that lung should heal. That's the goal. Other cases where this happens, so this can happen with a penetrating chest wound. If a dog fell on a fence or something penetrated the chest. Sometimes these big dog, little dogs, the big shepherd grabs the poodle. Sometimes they grab them over the neck or the back. They bite and they puncture the thorax, and the dog comes in respiratory distress. We usually try to get an x-ray if we can, because we want to make sure there's no penetrating chest wounds that are letting air in, because that will kill them. A severe pneumothorax can prevent them from expanding their lungs in severe cases. Lung cancer, if they've got a tumor on the lung, sometimes that will start to leak. You can remove a lung lobe. We have done what's called a lung lobectomy on patients, and they've got other lung lobes as long as there's other healthy lungs. And if we do, when we did at Purdue thoracotomies, we literally had the chest wide open. Those dogs were on a ventilator because they cannot expand their lungs. Once the chest is open, the dog has no ability to expand they'll try to breathe, but they cannot expand their lungs. So we put them on a ventilator. When we close them, we put in something called a chest tube, and we can put them on continuous drainage. We can hook a vacuum up and it will continually suck the air. Once it heals, they'll go back to a negative chest. So I just want you to realize is, the animal's ability to expand their lungs is dependent on that negative pressure and that negative pressure being maintained. Does anyone have questions about this picture? You're welcome for my artistic skills. Okay, let's go back to, okay, so it's usually easier to look at that picture and it's kind of a visual representation of what is happening. So inhalation, exhalation, got to figure this out. Now there's something called respiratory volumes. How much volume does an animal breathe? So tidal volume, minute volume, and residual volume is what we talk about. Tidal volume is the amount of air moved in one breath, one respiration. So and does everybody know that that's the pound sign for pounds? You will need to be able to calculate this for the test. So if we want to figure out an animal's tidal volume, and basically every animal under anesthesia, we figure out a tidal volume. It's part of calculating oxygen flow. It's part of calculating what the bag size that goes on the machine. So tidal volume, we have to make sure that the breathing unit, the bag, can accommodate the volume of air that animal needs to move in one breath. And we do that 5 mils per pound. So if I had a 40-pound dog, I would be 5 mils times 40 pounds equals mils. So a 40-pound dog breathes about 200 mils of air every time he breathes. That's his tidal volume. One breath in and out, one breath in and out. So I have to make sure that my machine and my parts are capable. Sorry, there wasn't supposed to be a period there. Thank you, Sean. It's supposed to be 5 mils. I didn't notice that little period. It's 5 mils. Yeah, not 0.5. It's 5 mils. Now, the next thing we figure out is minute volume. Minute volume is tidal volume times respiratory rate. So how much does this dog move in 1 minute? Now, you have to get a respiratory rate. So let me take my 40-pound dog. If I have a 40-pound dog, I know his tidal volume is 200 mils. And I'm going to times that. I'm going to say he's breathing, we'll say 10 times a minute, 10 breaths a minute. That's going to equal so if they breathe 200 mils in one breath and they're breathing 10 breaths a minute, then I know my animal is breathing 2,000 mils a minute. So on the test, I will give you a dog's weight in pounds, and I will give you the respiratory rate. And I will ask you to tell me the tidal volume and minute volume. Now, residual volume, there's a more complicated calculation for that. There is always a little bit of air left in your lungs. When you breathe in and out, your lungs don't completely collapse like a pancake, okay? When they decrease in size, there's always a little bit left over, and that's called the residual volume. That comes into play when you work with ventilators. People that are on ventilator therapy, people that are on ventilators right now for COVID-19, you know, what happens is we leave a little bit left at the end of the breath so that it doesn't suck away from the patient. So we don't want the lungs, we don't want to, like, when they exhale, everything collapses. And that comes into, so there's always a little bit left over. So if there's any questions about that, let me know, but that will be on the test, how to calculate that. Now, the handout that I sent you is kind of, this is the nuts and bolts of what it's talking about. Right now, this is a picture of what is happening. You remember those little balls, those little alveoli? Every one of those little sacs has a capillary going around it. And what happens is, we know this is the capillary. Now this is coming, this is an alveolar capillary. So this just went pulmonary artery, pulmonary arterial, pulmonary or alveolar capillary, which is a pulmonary capillary, okay, same thing. It's coming to the alveoli. Why is it coming there? It wants oxygen, right? So what's happening is the blood in this, see how it's blue? It looks blue because it's high in carbon dioxide and it's low in oxygen. It's coming to get. So on the test, how I want you to understand this is, if I ask you the blood coming to the alveolus, is it high in oxygen or is it high in CO2? You would tell me it's high in CO2. Now, right here, now the animal just took a breath. They just inhaled. So this is the alveolus. Obviously, it's high in oxygen, but it's low in CO2 because the animal would have exhaled the previous breath. Now they've inhaled more air in. So now this is high in oxygen, low in CO2. What happens is, as the blood is starting to pass the alveolus, This is the exchange that I've been talking about. This is where I say CO2 for O2. Because what happens is a high level of oxygen diffuses where levels are lower. I don't know if you've done this in chemistry yet, but laws of diffusion, if you have a high concentration here and you have a high concentration here, we have high O2, we have high CO2. Okay, they don't want to be that, they want to diffuse to the area of a lower concentration. So what's going to happen is oxygen's like, well, there's not a lot of oxygen here, so oxygen's going to go here, and CO2 goes, well, there's not a lot of, there's not a lot of CO2 up there, so I'm going to go up there, and they trade. Right here in the capillary, this is internal respiration. Everything I had talked about every other day is external respiration. Now we're talking about internal respiration, which is right here. So now the blood, they trade. It's called the diffusion gradient, going from high concentration to low. Now what's going to happen is the animal's going to exhale. So obviously in the alveolus, during exhalation, CO2 is higher. Oxygen is lower because the oxygen just left. And the blood going out here, see how it's red? It's now high in CO2 or high in O2, low in CO2. So air or blood in the capillary, high in carbon dioxide, comes to the alveolus. This is high in oxygen, this is high in CO2. They trade places, okay? Now see how that blood leaving is now high in O2 and low in CO2, and then the animal exhales the CO2 out, and then they repeat the cycle. This just keeps happening over with every breath, over, over, over. Now, I never totally make you memorize these definitions. Total pressure of a mixture of gases is the sum of the pressures of each individual gas, blah, blah, blah. Also, it's talking about what gas, how much gas is dissolved in liquids. So if we look at partial pressure, is how much gas is dissolved in the liquid, and our liquid is the blood, okay? So there is a pressure of O2 and CO2 in the blood of the capillaries, but it is dependent on the partial pressures of oxygen and CO2 in the alveolus. What that means is, again, depending on this pressure is going to depend on this pressure. And again, they want to diffuse back and forth. When you get into anesthesia, we get into blood gases, and we will take a sample from an artery. It's about the only time we stick an artery for a blood sample is to do a gas. And we look at PaO2, which is the partial pressure of oxygen. That tells us how much oxygen is dissolved in the blood. Now, when you guys go to the doctor and they put the little red light on your finger, that's a pulse oximeter. That measures oxygen saturation of hemoglobin. That's called an SpO2. But that is an estimation based off of the light reflecting off of hemoglobin. So there's a difference between PaO2 and an SpO2, which we get into later. But I just want you to know that depending on this, if this is high pressure and high pressure, they're going to want to switch. And that's how oxygen and carbon dioxide diffuse back and forth. Now, the brain, the respiratory center is in our brainstem. The medulla oblongata, right at the brainstem, this is where breathing is controlled. What this does is it sets your resting respiratory rate, and it tells your respiratory muscles how strong to inhale or exhale. So it helps with muscle contraction. Now, remember I brought this up. You can hold your breath for a short period of time. I mean, some people longer than others. If you were a swimmer or a diver, and then just normal people can't hold it as long. But what eventually is going to happen is the respiratory center is going to take over and is going to trigger a breath. So you can only consciously hold your breath for a short amount of time. So I want you to know where the respiratory center is. How the respiratory center figures out what to do. There is mechanical control of breathing. Remember, mechanical is something moving or pumping. If I say something is a mechanical function, it is the actual movement of something. You remember me talking about stretch receptors, okay? I talked about them in the bladder. I talked about them in the stomach. If you have an organ that stretches, it needs to get feedback of when to stop stretching. You know, obviously, like I said, if you eat at a buffet, you're going to get to a point, maybe you force yourself, but you're going to get nauseous. And then there should be feedback. Your stretch receptors go, stop, stop. I can't expand anymore. What happens in the lungs is that if you look at this step by step, nerve impulses are sent to the respiratory center when the lungs hit a certain point of inflation. So inhalation, there's a little alarm, beep, 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 stretch receptors go, okay, we're stretched. They will send a signal, the brain will stop inspiration, and then it will send a signal or feedback to initiate exhalation. And then when the lungs get to a certain point where they're flat, beep, 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 signal is set to inhale again, okay? So the inhalation and exhalation, or the triggering of those impulses to initiate inhalation and exhalation, is controlled by the respiratory center and the medulla oblongata. What happens is you should have a very rhythmic respiratory pattern. And I will tell you, a normal respiratory pattern is watch yourself or listen to yourself, feel yourself breathe. This is how I breathe. I go, do you see how inhalation goes? There's something called the inspiratory to expiratory ratio. I'm teaching it in anesthesia. I just taught it. Inhalation to exhalation. Inhalation to exhalation. And you wouldn't want to see a... Do you see how it took me like 3 seconds? 3 seconds. Your inhalation should always be shorter than your exhalation. That is a normal baseline pattern. When it flips, when you have an animal under respiratory distress, that is different. Gabe, hang on a second. I haven't had a chance. Hang on. Wait, can you 1 second, please? Okay, so when this is working properly, we get a normal baseline pattern. The problem is if we have injuries, if there's like a hit by car or a cervical fracture, anything that potentially damages the brainstem can affect a person's ability to control breathing. Some of those people would have to be on a ventilator to control their breathing. Okay, so any damage here in the brainstem could affect this normal rhythmic pattern. But I want you to know inhalation is always shorter than exhalation. Now, the chemical control of breathing, so these work together. There's mechanical control uses stretch receptors. Chemical control only kicks in when something is out of balance. And this was this whole day one, I talked about homeostasis. Homeostasis is the body keeping everything in balance. So the body is constantly using the stretch receptors, but it's also measuring the content of the blood. And these receptors are in the carotid artery, the aorta, and the brainstem. So in the arterial blood, at the main arteries, the carotid and the aorta, the carotid arteries are going to the brain. The aorta is going to the whole body, and the brainstem controls breathing. They're monitoring CO2, pH, and O2. Now remember what I told you, CO2 is supposed to be 40 millimeters of mercury. pH is supposed to be 7.4. As long as we're in that range, the body is probably going to keep respiration at a nice normal rate. But sometimes things are out of whack. CO2 and pH go together. If CO2 in your blood starts to increase, if we start to get up in 50, 55, 60, remember you're supposed to be 40, you're going up, what's going to happen is the blood pH is going to start to go down. The blood is going to become more acidic. Anything below 7.4 is acidic. This situation is called respiratory acidosis. When you have an elevated CO2, even if I will tell you, you can't always monitor pH. You need a blood gas to do that. If you don't have the ability, if I have a machine, I have a capnograph that measures CO2 during anesthesia. If it's elevated, say above, like I said, 55, 60, my patient is going into respiratory acidosis. What that should link, or what it should trigger, is the body should start to breathe deeper and more often. Remember, I used this example. If you were sitting in lecture, being bored to tears listening to me, and you were breathing really shallow and you're practically falling asleep, and then you're not breathing very deep, and then all of a sudden you go, you do what's called a sigh breath. That is the body measuring CO2. The more shallow you breathe, the higher your CO2 is. Then it triggers a breath. And then you go, the deeper you breathe, the more CO2 you're going to get rid of. And then your CO2 comes down and you go back to normal respiration. Now let me flip it. If for some reason our CO2 is going down, say I'm in the 30s, 25, what's going to happen then, CO2 is going down, pH goes up. So then you might go to 7.5, 7.6. Now a patient is in what's called respiratory alkalosis. Anything above 7.4 is alkaline. This is a respiratory component, so we call it respiratory alkalosis. So again, I just want you to know they do this. CO2 goes up, pH goes down. CO2 goes down, pH goes up. Now, what will happen, remember when I said you just took a sigh breath? If you notice, sometimes you don't breathe for a second. It kind of like slows down, and then you kind of go back to normal. Because the body's response to a low CO2 is to decrease the rate, how often you breathe, and decrease how deep you breathe. Because what is the body trying to do? The body is trying to retain CO2. Now, in anesthesia, sometimes people bag the animal. I mean, you're supposed to about every 5-10 minutes give them a breath. Sometimes people get overzealous and they squeeze the bag a bunch, and then their CO2 goes way down. And you want to try to keep it, like I said, 35 to 50. When I monitor anesthesia, I'm like, as long as you're in that range, and 40 is my normal, 35 to 50 is my range. But if you say you bag and they go down to 25 for a CO2, what you're supposed to do is back off of ventilation. I'm like, don't breathe for them for a minute or two. Because what will happen, the less often you breathe, the CO2 is going to come back up. It's definitely, you don't want it low and you don't want it super high. So we have to balance. Now, the body is going to try and do this on its own. The body is going to adjust respiratory rate and depth based on what it's getting data-wise. But the thing that I preach is that under anesthesia, an animal does not have, as much strength. They're anesthetized, so they don't breathe as deep as they would if they are awake. They also are respiratory depressed, and they don't breathe as often as they were going to be awake. So if an animal doesn't breathe deep enough, and if they don't breathe often enough, automatically they're going to have a higher CO2. The higher their CO2, the more I have to help them, okay? In an awake animal, you should see a sigh breath. Sometimes Bo's sleeping next to me, and all of a sudden he does a big old stretch, and I watch him, and when he's sleeping, he's about 6 breaths a minute. His heart rate the other night he was sleeping was 54 beats a minute. He's a 62-pound boxer. So when he's asleep, but every once in a while you see a, even when people are sleeping, and that's the body trying to control the level. So what the big thing to understand, which moves which way, what is normal, but also understand that if you breathe more often and if you breathe deeper, you're going to get rid of more CO2. The more you expand the lungs, the more CO2 you cause to be expelled. So everybody needs to understand that. Now, oxygen level, everything I've been talking about is CO2. Now, CO2 is the most important thing in driving respiratory rate and depth. There is an effect on oxygen levels. So hypoxia, hypo meaning low, oxia meaning oxygen concentration of the blood. Some people call this hypoxia, some people call it hypoxemia. So if a patient is hypoxic or has hypoxia, it means they have low levels of oxygen. It depends on how I'm measuring it. That's what the thing on your finger is for. You go to the doctor, they put it on your finger, it beeps. Normal oxygen in the blood is 95% or greater. And SpO2, oops. Oh, I can imagine, Jonathan. It's a very scary feeling. If you've ever been short of breath, and maybe people that have asthma can definitely relate, you start to get deprived of oxygen and you can feel your body is going to try to compensate. It's not as clear cut as CO2. That's what it's trying to say, is that if the body detects that your oxygen level is dropping, it's going to try to increase rate and depth. So, similar to getting rid of CO2, but the obvious thing is they are trying, yeah, wearing a mask right now, a lot of people have an issue with the panicky feeling. Or now, your mask, I don't want anybody to think they're going to have too high of a CO2, because it should allow enough exhaled. Since CO2 is a gas, it should be able to escape the mask. It depends on how tight the mask is to your face. But yeah, people have worried about that or have complained about feeling lightheaded. So oxygen levels, the body is going to try and trigger breathing. If I have a low oxygen on a patient under anesthesia, I try to ventilate them more. And sometimes by me ventilating them, which is squeezing the bag, I will see the oxygen levels rise. And that's what you're trying to do. Now, the body will try to trigger this. If the animal keeps dropping, like if oxygen keeps dropping, basically what's going to happen is the nervous system has been firing. Finally it goes, I'm done. I'm overstimulated. I can't handle it. And then what happens, there's no impulses sent to the respiratory muscles and the animal stops breathing. So this is why if an animal comes in severe respiratory distress, we really have to try to get oxygen in them, whether that's putting them in an oxygen cage. Sometimes we just hold a hose of oxygen in front of their nose. In severe cases, if it's affecting the lungs, we may have to anesthetize them, put a tube in the trachea, and actually squeeze and ventilate the lungs. When we get into like pneumonias or constrictive pulmonary disease where the lungs can't expand, sometimes just putting oxygen in front of them is not enough. Sometimes you have to force it in by ventilation. But I do want you to know it can go crazy to the point where it just kind of is like, done. So that would be in severe cases. So that's why, like I said, it's very important to get on top of it. So I want you to know what causes, to me, I want you to understand what means what. If I tell you it's a high CO2, I want you to know the pH is low. I want you to know, why does an animal increase its respiratory rate and depth? It's probably trying to get rid of CO2 potentially trying to bring in oxygen. But the first thing I'm going to think about, CO2 is really what controls your rate. So that's the primary driver of how often we breathe, how deep we breathe. And that feedback is monitored in the blood by the brain. So the brain, when I get into endocrine in about 3 or 4 more weeks, I talk about basically it's like a control center up here. And it has all these systems to monitor your body, like the body is a plant. And it's monitoring this department and this department and this department. So what you have to think about is, well, what is the brain assessing by doing this? And what is it going to do because of this data? Okay. Does anybody have any questions about anything we went over thus far? Okay, well, so homework tomorrow, no heart attacks. Homework tomorrow, and then make sure you have your homework available. I don't know if you want to print it out or you'll have it on your screen, but we will go through the questions one by one. I'll review that handout, the blood flow again, as a review.